Good afternoon, everyone. I'm Dr. Deepanjali Adurga, radiation oncologist at Fortis in Hiranandani, and I'm going to be talking about this oral abstract which was presented in ASCO GU this year in February by Tamim Niazi et al. From the Canadian group, which is the Genitourinary Radiation Oncology group of QBIC, and this is the PCS9 study, that is metastasis-directed therapy in addition to the standard systemic therapy in oligometastatic CRPCs, a randomized phase 2 trial. So ADT and enzalutamide is one of the standard options for ARP inhibitor naive metastatic CRPCs. There have been retrospective studies showing benefit of MDT in metastatic HSPCs. With this in mind, the PCS9 study was designed to evaluate the role of MDT using SBRT to the standard systemic therapy for new treatment option for oligometastatic CRPCs. Now, this study was a multicentric open label study carried across 13 centers in Canada. It was initially designed as an adaptive phase 2, phase 3 randomized study. The initial sample size for the phase 2 study was estimated to be about 130, and for phase 3 was 374, which included the 130 of the phase 2. However, this trial was actually halted at phase 2. Now, this was because the ARP inhibitors became the standard of care for metastatic hormone-sensitive prostate cancers, and the investigators found it extremely difficult to get patients for enrollment, and that is the reason the trial was halted at phase 2, and the results reported are of 100 patients of oligometastatic CRPCs. Now let's look at the patient population. So it was a primary treatment for metastatic CRPCs, oligometastasis, which included 1 to 5 mets. Now, interestingly, the investigators excluded brain and liver metastasis from the cohort. No prior ARPI inhibitors were allowed, except for docetaxel, which was used if it was used at the metastatic HSPC stage, and patients should be going ongoing ADT and with the ECOG of 0 to 1. These patients were then stratified for site of distant metastasis, which is visceral or bone or both, and number of metastases, that is less than 4 or 4. The randomization was 1:1 to the standard arm, which is enzalutamide plus ADT, and the experimental arm, which was addition of SBRT. The primary endpoint was radiological progression-free survival. The secondary endpoint was biochemical progression-free survival, the quality of life, time to subsequent therapy, safety and toxicity profile, and the overall survival. Now, if you look at the baseline characteristics, both the groups had a similar disease characters as well as the patient characteristics. There were 48 in the standard arm and 52 in the experimental. The median range for age was 72 in both. Around 80% of the patients received prior radiotherapy to the prostate or the prostate bed, and around 85% of the patients had less than 4 metastases. Now, if you look at the site of metastasis, bone was the most common, followed by lymph node metastasis. Now, looking at the primary endpoint, which is radiological progression-free survival, the authors found that the median RPFS was 4.6 in the SBRT arm, and it was 2.3 in the standard arm. That is almost double. The RPFS was almost double in the SBRT arm. Similarly, if you look at the secondary endpoint, which is the biochemical PFS, in SBRT arm it was 4.6 years compared to 3.1 years in the standard arm, with a hazard ratio of 0.58, that is a 42% risk reduction in biochemical progression with SBRT. Now, if you look at the subsequent line of therapy, that is the time required for the next line of therapy in the standard arm versus the SBRT arm, even in this endpoint, we see that SBRT, the median time to subsequent therapy was 5.1 in SBRT group compared to 2.9 in the standard group. That is almost 2.2 years treatment was delayed in the SBRT arm. Now, for overall survival, obviously the median overall survival was not met, and The hazard ratio was 0.71, which is again not statistically significant, even though the authors estimated that there might be 29% risk reduction. Of course, only time will tell us what exactly is the overall survival. Now, if you look at the safety profile, which was another secondary endpoint, the safety profile was more or less similar, and it was as per the enzalutamide toxicity profile. The only two toxicities which were seen additionally in SBRT was the pain or the flare pain which we see at the SBRT site, which was seen in 4 patients, and asymptomatic pneumonitis which was seen in 1 patient. So the authors concluded that the addition of SBRT in oligometastatic CRPCs definitely improves the radiological progression-free survival over the standard ADT plus enzalutamide, as well as the secondary endpoints which were the safety profile, the time to subsequent therapy. Hence, it should strongly be considered in CRPCs with oligometastatic sites. Thank you.
Thank you. And I think the last speaker in this session is...
Amit sir, this is basically oligoprogressive CRPC. Because that term has never been used. So it is basically the oligoprogression in only 4 or 5 sites happening, or no?
No, this is not oligoprogression. This was primary oligometastatic CRPCs.
So it is CRPC with an oligoprogression, no?
No,
then only you are able to
at
give
the time
No.
of getting the CRPC, those 5 sites have new bony lesion or something.
It is 0 to 5. Anything, any of it. It can be one. It can be 1 site also. It can be 2 sites also. It's not oligoprogression.